I don't know if they have any classes next door. So mitral stenosis makes a diastolic murmur, and it's the only thing that sounds like it. And you probably won't hear it too much, but you might get questions on it because it's one of the lists sort of thing on PANS. So the term you might want to remember that goes along with mitral stenosis is an opening snap and a diastolic rumble. And it's really hard to sing. I have a tape I'm going to play for you when we do hard sounds. Dr. Chisner, he sings a lot better than me. But it's so you hear this presystolic accentuation that is. So the reason why you have this murmur in diastole is because when the valve is stenotic and what's happening in diastole with the mitral valve? What position is it in, open or closed, in diastole? It's open because in diastole is when the heart's filling with blood, right? In systole, the AV valves close and the blood ejects out the aortic and pulmonic valves. So those valves open in systole, and in diastole, then those valves are open in the AV position. Does that make sense? Can you picture the blood? So because of that, that's when it makes the noise in diastole, because it can't open completely. And you might hear an opening snap because it's stiff. And if the opening snap is gone, it might be so stiff it doesn't even make an opening snapping noise. So you don't always hear the opening snap of the mitral valves. So you hear closing sounds of valves when they're stenotic in the aortic position. And then you hear opening snap when you have in the mitral position. Anyway, so the diastolic rumble is the turbulence of the blood flow, and it gets a little louder right before systole, because the heart's starting to squeeze, and it just gets louder. So we'll practice drawing that too. So it's bump, that's the first sound, bump, and that's the second heart sound of the opening snap, followed by the murmur. Bump, kind of like that. So there's a picture of it. It's all calcified and scarred up from the valvulitis from the rheumatic fever, which is the most common cause of mitral stenosis. And the reason why mitral valves affected first in the majority of cases is because the flow is lower in the mitral valve. Think of the pressure gradient between the blood in the left atrium, which we said is about how many millimeters of mercury, the left atrium? Maybe 10, yeah. And so it's just flowing through the mitral valve. It hasn't picked up pressure yet. So what's the pressure in the aortic valve? Well, during systole. Yeah, so it could be 100, 120 millimeters of mercury. So if you have bacteria in your bloodstream and you're pushing it really fast past the aortic valve, it's less likely to get stuck on it than an area that's of lower flow. So the AV valve in the center of the heart has lower flow than the pulmonic valve and the aortic valve. So they're less likely to get infected. And they're also less likely to make clots. So we've had some people that refused to take their clot-busting medicine that had artificial valves. And I had a few people that had it in the aortic position, and they're much less risk for making clots on that valve than they are if they have a mitral problem, just because the blood's going faster. So it's less likely to clot, and it's less likely to collect bacteria because of the flow. Kind of like a water pick, versus you're blasting past that, versus just it pulling it somewhere. Problems. So anyway, they grow. They're called vegetations. They grow vegetations on the valve, or it just gets calcified and thickened from the scarring, from the inflammation, from the rheumatic fever. It's actually not the acute infection that causes the problem. It's the long-term, and we'll talk more about the process of rheumatic fever later. Okay, here's a sign that everyone gets all excited about, and I wouldn't be surprised if you had a question about this. This is a classic sign of an X-ray of mitral stenosis. Remember we talked about the left atrium, so both with mitral regurgitation, but particularly mitral stenosis. If the blood can't get through the left atrium and pass through the valve, what's going to happen to the blood in the left atrium? Some's going to be left behind. When it's left behind like that, it's going to make the left atrium enlarge. And this is the left atrial border. This is the left side of the heart, because it's reversed. Remember that? It's not the right side of the heart, this is the left side of the heart. So if you were standing here, your heart's pointing to the left side over here. My left, your right. So that bulging, and sometimes they just say straightening, is the left atrium. So that's left atrial enlargement. So that's part of it. Here, we used to do these barium swallows, and they're showing some bulging on the lateral view there. And then here they're showing cephalization of flow. What this means is these are pulmonary vessels coming through here. And this is called cephalization. You can't see it that well in this picture, but just the fact that you can see those blood vessels in the upper part, cephalization, cephal means head, just the fact that you can see those blood vessels up there and that they're prominent means that you have increased what kind of pressure? You've got some pulmonary hypertension going on because of that left atrial enlargement, that left atrial pressure being higher. It's showing up on the x-ray. So when you have cephalization of flow and straightening or bulging of the left atrial border, x-ray signs of mitral stenosis. Here it's just kind of straightened. But that is not a normal shape. Remember a normal chest x-ray looks like it comes down like this. It doesn't look normal at all. And also another way to measure the cardiothoracic ratio, and we use these double lined rulers, these big plastic rulers that go all the way across the chest, and you measure the width of the chest from the widest part. So you put your edge of your ruler here, and it goes all the way across, and you go to the rib border here as wide as you can make it, and that's the AP diameter of the chest. And then you put your ruler here on the widest part on the right heart border, and then so it's got one line up there, and it's got a second line on the ruler down here. So you have your ruler here at the widest part, and then you look down here, and you get the measurement on the lower line here. And so you have the widest width of the heart, and if the width of the heart is greater than half of the width of the chest, then you've got cardiomegaly. So this should be less than half of the total width of the AP. I don't have one of those rulers to show you, but maybe I can get one. Okay, so there's the opening stent followed by the diastolic rumble. Does it make sense? You're going to hear best in left lateral decubitus. You want to bring the apex of the heart closer to the chest wall. So you put them in left lateral decubitus and even kind of push them, lean them over a little bit. If you're a small female and the patient's large and you can't reach over them without wrapping your body around theirs, then you put my hand on their body and I kind of inch around the bottom of the exam table and I listen to them from the front. They can get in there, and then you just keep your arm on them to keep them. Well, I'll show you that when we do our heart sound lab during PD class. So if you increase the cardiac, let's say you can't hear it, but you're going to make the heart faster, so it might be a little harder. So their heart's going, but it's super soft, and you're not really sure if you heard something. So I just help them do a couple of sit-ups. Like have them sit up 3 times. I put my hand behind their back and I help them do it. And then I quick push them back on their left side and put my stethoscope there, and it gets real loud. So that's because I increased their cardiac output with that little bit of exercise. So that's a really good trick for increasing the loudness of a murmur. But also you've got to recognize when S1 and S2 are, because it's going to be faster. Understand why there's no respiratory variation? First of all, we're not listening for mitral stenosis. We're not looking at it's only the pulmonic valve, and it's going to have a respiratory variation. This is not going to change with respiration. It's not affecting it. Okay, in the beginning they did open mitral commissurotomy. They stuck their fingers in there. They made a cut on the outside between the ribs. It was really painful. They didn't do median sternotomy, which doesn't hurt as much. So they opened them up between the ribs, and they put their fingers in there, and then they got through the heart, and they just cracked it open with their fingers. Now this is before they had bypass. They were intubated and asleep, but they weren't on cardiopulmonary bypass though. They had to get in there quick and do that and sew that up. And definitely, if they have mitral stenosis, they're going to be on treatment with water, pills as diuretics, and an ACE or an ARB. And it's very common to get atrial fibrillation, which is a rapid, irregular heartbeat, because whenever you disrupt the anatomy of the atria, that's where's your sinus node at? Right atrium, and then the fibers spread across into the left atrium. Once you stretch that atrium, it's more likely to fibrillate. So the upper chamber quivers like that, and the bottom just, whenever a heartbeat gets through to the bottom, it'll squeeze. So you got the upper part quivering and the bottom part squeezing irregularly, because you don't get the regular signal from the sinus node anymore. You get the signal from the fibrillating atrium. Really, really common with mitral stenosis. And those people have to be anticoagulated with warfarin, because the clots form in both atria, not just one atria. One atria never fibrillates, both atria fibrillate. And in fact, the place where the fibrillatory foci is really in the pulmonary veins. As well as the atrium. So surgeons do procedures to try and cure atrial fibrillation by trying to cut it and ablate it. And electrophysiologists also put catheters in there to try and ablate it. And we treat it with drugs to try and control it, but we definitely have to anticoagulate for stroke prophylaxis, because the clots go through the valves and then out the heart and up to the carotid arteries. Okay, so if they have mitral stenosis, obviously you can do echoes every year. More frequent if symptomatic, i.e. if they start having episode of heart failure, you want to get an echo and see what's going on. So insurance will pay for an echo once a year, but if you're acutely ill, it'll pay for one sooner. Or if we want one, but we're not sure if it's going to get covered, we write limited echo. So we just get paid for limited echo, which we're allowed to do as often as we want, but we still do the whole echo. But we just charge for just doing a limited one. So that's one way you can do things that insurance companies try to tell you how to take care of your patients, but sometimes you have to do things to do what you want to do. Okay, I had a woman, this was really sad. She was pregnant and she had mitral stenosis, and she needed to be on warfarin because she also had atrial fibrillation. And I remember Dr. Kramer, John Kramer, he told her she had to have an abortion. So I was really sad, because the warfarin totally destroys the baby. So they take them off of warfarin if you have an artificial heart valve, and you can have heparin shots when you're pregnant, but you cannot take warfarin as teratogenic. I never forgot that woman. So. Do you see why stenotic valves have a poorer prognosis than regurgitant valves? A regurgitant valve just allows a little extra blood into a chamber, but a stenotic valve actually, it literally can stop it. And that's why you start getting syncope with people. Syncope is passing out with people that have aortic stenosis, because the blood cannot get past that. It's more damaging. Stenosis is much more severe than regurgitation, which can be tolerated maybe indefinitely. Sometimes people with regurgitation never have to have a valve replaced. They just have to be observed to make sure that the pressures are normal inside the heart. So maybe you're starting to see that cardiology is all about physics. It's all about this pump, and it's all about keeping the pressures inside the heart. We want normal intracardiac pressures, low heart pressures, low blood pressure, normal blood pressure. Once you start getting elevated intracardiac pressures, you destroy the shape and the function of the heart. And that's what leads to heart failure and valve failure and fluid retention and fluid in the lungs if this pump doesn't work perfectly. So you want low intracardiac pressures, not elevated pressures. And then you have to learn all what's normal numbers, like what's normal pulmonary numbers and all that kind of stuff. You see how it's all about physics and the pump working? It's just fascinating, and it's just a great, it's been great for me. So maybe some of you will go into cardiology. Okay, so now we're going to talk about aortic valve disease, which is really, really exciting right now because they're being able to fix aortic valves in people that they were too old or too sick and they couldn't do anything for them, not surgical candidates, and now we can fix them, and it's just really exciting time, and it's very common, and every single one of you in this room is going to hear aortic stenosis when you go on rotations, I guarantee it. So you're going to have to learn what this murmur sounds like. And most of it is degenerative aortic stenosis, it's just age-related. So the etiology, remember how we had that etiology of mitral disease? We had like congenital, which wasn't that common, it was mitral valve polyps, and we had infectious and degenerative. And this one, so congenital is when it's bicuspid. Remember the picture, the bicuspid aortic valve? The raft between two of the sections was closed. So that made it bicuspid, 2 cusps instead of 3 cusps, tri-leaflet valve. And degenerative could cause either aortic stenosis or it could cause aortic insufficiency or regurgitation. Most people say AI. Okay? So it can either leak over time because of it, the leaflets don't meet perfectly. Maybe there's some degeneration of the ring, the connective tissue ring, or the leaflets themselves, or some stretching of the heart, maybe from hypertension, pulling them apart, or some disease of the aortic root. There's many connective tissue diseases that can affect the aortic root. Marfan's being a prime one. Or rheumatic, which is not as common. Or why did I say rheumatic aortic diseases would not be as common as mitral valve disease? Why? The pressure on the bacteria, exactly. So you've got the lower flow, slower flow around the mitral valve is going to be infected first. But people could have, they could have several valves that are affected by rheumatic fever. They might have both aortic and mitral valve disease. Much less often do you see right-sided lesions, pulmonic or tricuspid valve disease with rheumatic fever. So obviously you're at higher risk for aortic dissection if you have aortic stenosis because it can affect the wall of the artery. It's muscular. Do you have a question?
At what point would you decide that a patient needs to have transplant versus when you replace all 4 valves, or is it point when you kind of decide you're not going to be replacing it and try to do that synthetic part?
Okay. Who wants to know when someone becomes a candidate for transplant due to valvular disease? Valvular disease is less often a cause of a need for a heart transplant than just cardiomyopathy, usually ischemic cardiomyopathy, where you have had many heart attacks and you've got dead heart muscle and poor heart function. And the second most common cause of needing a transplant, I was on a transplant team for 8 years, is a virus that infected the heart and ruined the heart. Valvular heart disease we're able to treat pretty well with valve replacement and use of ACEs and ARBs, so very infrequent to need that. Maybe if someone had congenital heart disease, especially an infant really had severe disease, they might get a heart transplant in infancy. We'll talk about that more when we do the heart failure lecture. Okay. So it's more common in men, bicuspid aortic stenosis for some reason. Remember I said, remember what coarctation of the aorta is? Do you need that for the pants? Remember coarc? The constriction of the aorta past the blood vessels? Okay. So obviously if you have aortic stenosis, you're going to get some thickening because the heart is pushing against the pressure, not able to get it past the valve, so it'll get thicker and try and get the blood out of the heart. So eventually that works at first, and you maintain your cardiac output, but eventually the heart says, I'm exhausted, I cannot do this anymore, and it just blobs out and you get a dilated, bad situation when you want to replace that valve before the heart dilates. Because once the heart dilates, what's the other word for that? Remember I said, you can do this to your house, but it's bad for your heart. Remodels, yeah. Once the heart remodels like that into a different shape, becomes globular, it might not come back. So you don't wait for that. So that's why you do echocardiograms. Really, you follow them closely for their symptoms. Okay, so the main symptom is just fatigue and shortness of breath. And why might they get chest pain if they have aortic stenosis? We talked about this yesterday. Do you remember? Why? Coronary arteries are close by and they could be involved. Or another thing is probably at least half of people that have aortic stenosis have coronary artery disease. Because if they have degenerative type aortic stenosis, it's just over time, they also have they may have high calcium scores and they may be depositing calcium in their coronary arteries as well as their aortic valve. So I need you all to watch a program. Who has Netflix? Okay. All of those of you that have Netflix, after you watch this, send me an email. Tell me you watched it. I want to see how many people saw this. It's called the Widowmaker. Go, write that down and watch The Widowmaker. It's all about calcium scoring and politics and why we don't do calcium scans on every person, and you should all have a calcium score, especially if you're older or you've got chest pain. Or instead, they go right to heart cath and put stents in your heart when we could know you have this problem and fix it first. So I'm expecting quite a few emails that you watch The Widowmaker, okay? And then those of you that don't have Netflix, make a friend with one of these that does, and watch it, okay? Maybe have a party and have some popcorn without butter and all watch The Widowmaker together, okay? I thought about showing it here. We don't have enough classes. I wanted to do that the first class. Let's watch this movie, so. It's a documentary, yeah, it's about 2 hours long, maybe an hour and a half because there's no commercials. Really good. Okay, so finally, and this is what I told you yesterday, so this is what I want you to remember. As the gradient increases and the valve area decreases, eventually you don't get enough blood to your head and you can have syncope. It is really severe. So that's a sign of severe aortic stenosis. Hopefully you took care of them before they have a syncopal episode. Does everybody remember that concept? We're good with that? Gradient increasing and valve area decreasing, so just a little bit of blood squirting through. Okay, so let's say they also have hypertension and you decide to give them one of those miraculous drugs I just told you about. You put them on an ACE inhibitor, which I'm not against giving them the ACE inhibitor, but let's say you decide to increase the dose because their blood pressure is 150 systolic. Well, what might that do? We talked about that yesterday. Anybody remember? Yeah, make them too low. Make them too, even though the arterial pressure might still be high, you just increase the gradient because you drop the blood pressure on one side of that valve closer to the heart, inside, and on the outside, it's still high because it can't get through there, but their blood pressure is in essence, the rest of their body, it's lower, the rest of the blood vessels, but you can't fix that blood vessel that's the aorta. You can't fix that. The aortic valve is part of the aorta, top of your heart. So it might make them pass out. So you accept a little bit higher blood pressure in a person with aortic stenosis. You do not panic that their blood pressure is 150. Just say, okay, at least it's not 170, 180, or it's going to cause damage to the rest of their body. It's too high, but you know you're going to fix that definitively later. So you have to manage their blood pressure a little bit differently. And the same thing is we don't want to make them hypovolemic. You give them too much diuretics, what do you think that's going to do? They're not going to maintain enough pressure through that valve. So be careful with diuretics and be careful with ACE inhibitors and ARBs. So they usually if they're going to have surgery, they get a heart cath too to see if they need coronary bypass at the same time their chest is opened up or stents put in. Okay. The exam. This is a classic exam, and I'm sorry to just talk about it. You need to hear this, but it sounds like, well, is it going to be a systolic or a diastolic murmur? You guys got to start, yeah, it's systolic. You got to start thinking about physics here. This is just a pump. So it's going to be systolic because it's as the blood's getting pushed through the valve when the heart's squeezing. So it's systolic. So it's going to be very harsh, and because it's turbulence trying to get past that valve. It's a crescendo, decrescendo murmur, diamond shape, because it starts to go through that valve, gets louder, and then it falls off. And where do you think you're going to hear it the best? In the what area? The aortic area. Where is where? Where's that? Right, second right intercostal space. And where might it transmit to? What's attached to the aorta and the aortic valve? Yeah, the carotid. So you're going to hear it radiate to the carotid arteries. And sometimes it's louder on the right, sometimes it's loud in both. But it almost always radiates to the carotids. And when I say radiate, if you inch up, if you start in the right second intercostal space and you inch up, you'll hear it the whole time. You won't hear it here and then hear nothing and then hear it. You're going to hear it as you move your, that's what I do. I just inch my stethoscope up and I hear it, hear it, hear it. The same sound in the neck is the same sound in the heart. So it's not a carotid bruit, it's a transmitted murmur. And it sounds like this. Rawr, 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 rawr. And sometimes it sounds like a goose. It goes, whoop, 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 whoop. And you cannot hear S1 and S2 because the murmur covers it up. And it's usually loud like that too. It's like a, well, it won't be that loud, but it'll be like at least a grade 2 out of their 6 gradings for murmurs. We'll do that some more later, but it's a harsh systolic ejection murmur in the second right intercostal space that transmits to the carotids. That's the stuff you got to remember about that. And you've got to remember the symptoms of aortic stenosis: fatigue and shortness of breath, and ultimately syncope. Okay? Really important murmur. You're going to hear it. You can see why the A2 component of the S2 gets softer as the stenosis becomes more severe. Sometimes they say you could have an ejection click with it. As the valve opens up, it make like the mitral valve can have an opening snap. You might hear an ejection click. I don't hear them so much because the murmurs usually just covers that all up. And you often feel a thrill. That's another pathodemonic thing. So remember I showed you on Bob how you feel a thrill. You put your whole hand on it and you really mash in and feel it. Have them lean forward and you feel that thrill, buzzing kind of feeling, vibration. And sometimes you'll hear the aortic murmur all the way through to their back. You just get it really quiet in the room. If you can't, if the noisy breather says, stop breathing for a second. Don't breathe, and then listen. Okay, so what you do is you manage their hypertension. They almost always have hypertension, but you don't worsen the gradient by lowering blood pressure too more. Use ACE cautiously, meaning make sure their symptoms aren't worse. And we give them all statins because this whole inflammatory process and calcification of the valve is worsened by calcium. So we cut their calcium in half and we put them on a statin. A statin is, and who's heard of what a statin when I use that word? Who's heard of that? Who doesn't know what the heck I'm talking about? Okay.
I've heard of it.
That's okay. That's okay. Statin, they all end in the word statin. So now for top with farm, you've got to just memorize the ending. On the pants, you will not get any trade names. So if they talk about a statin, it could be atorvastatin, simvastatin, rosuvastatin. There's all, but they all end in statin, and they lower LDL cholesterol. We're going to do a whole lecture on lipids. Okay, well, that's all I'll say about that. They give any heart attack patient gets put on a statin, even if their cholesterol is normal. Any person with aortic stenosis gets put on it, even if their cholesterol is normal, because we're not giving it just to lower cholesterol, but to reduce inflammation. And aspirin, just for this little bit of chance of clots forming on that abnormal valve. If they have a significant gradient, you don't have to worry about the numbers too much. They need aortic valve replacement. The bioprosthetic valves don't last that long, so if they're 80 years old, go ahead and put it in, but if they're 40, you might want to consider a mechanical valve so they're not faced with a second surgery. Right now, the trans-aortic valve replacement is only for people that are not candidates for surgery, so you can't just say, oh, we'll just do one through your leg with a catheter. You don't have to have your chest opened up. They have many sternotomy incisions they make, just a little vertical, they don't know how they do it. They just do it right next to the chest, and they just crack one rib. It's kind of painful, and they do it through robotics because they can't get their fingers in there, so they use a machine to get that in there. So they can do mini sternotomies for ABR, and they're only in the hospital for 2 or 3 days instead of maybe 5 days for a median sternotomy, a big incision. So normally the way they do open heart surgery is they use a saw. They saw through the whole sternum, which is actually less painful than when they did those surgeries on the in between the ribs. So and then they put the square plate on there and they crank the chest open, and so people get a lot of pain in their back from the chest being the muscles being pushed out of an abnormal place. They put them on cardiopulmonary bypass, and that's what I did when I was a beginning PA student. I got to stand there and cut the stitches. They lower the valve down with all these. It's just beautiful. All these strings through it, and they push it down in place, and then they tied the knots. And my job was to cut it. Boy, my hand was shaking. Go in there and to snip all those. Just like a little kid, I was just like baby. I was just right out of high school, went right into my PA program because it was a 4-year. They didn't have any master's programs, so I didn't have to go to college first, though. It was college, same time. So anyway, and it was all Cleveland Clinic, and it was all really sick people, and so they just threw me right to the wolves, like right away. And it's sick, so I got a great education with wonderful doctors. Scary though. Okay, so anyways, a porcine is a pig, and a bovine's cow, and equine's horse. I told you that yesterday. An allograft is a human or a homograft, and that is probably the best kind. But there's not very many of them because they come from a cadaver, so they don't have a certain supply, and they have to fit the person you give them to because people's hearts get larger as they get older. Okay, now for children who are growing, they sometimes do a Ross procedure, was where they take the pulmonic valve and they take it out and they put it where the aortic valve goes, and that it'll continue to grow. So the kid that needs the aortic valve replacement, which isn't that common, so a lot of times they may have complex congenital heart disease because they don't have degenerative aortic stenosis, obviously. And if it's congenital aortic stenosis, remember I told you it might not be needed to replace it for how long? Remember I told you what decade? If you had aortic stenosis and you were born with it?
25.
It's more like 50 years. The 5th or 6th decade before you get symptomatic, because you tolerate that pretty well. It's not sealed shut that bad. It gets worse over time. So that's one that people tolerate for a long time. But if a child needs it for a different reason, then they sometimes do this Ross procedure. It's just so they might need the pulmonary valve, but the pulmonic valve doesn't have the same work as the aortic valve, right? What's the pressure in the pulmonic valve? Maybe like 20, probably even less than a child, 20 millimeters of mercury pressure in the pulmonic valve. So that's going to last a lot longer because valves are like anything. You only have so many million heartbeats in your lifetime before your heart's going to wear out. So you think of valves taking all that stress of all those heartbeats, a pulmonic valve will last a lot longer. So it's better to put it in the aortic position because it's structurally the same. Okay, so anyways, the follow-up in aortic stenosis, pretty much the follow-up's the same with everybody. You do an echo every year, you see them in the office, you ask them about symptoms, and you let them know what to look for. You say, you ever pass out, you get back here right away if that starts happening, that kind of thing. So passing out from aortic stenosis is not usually from a rhythm heartbeat problem, it's usually because of a flow problem. So if you fix it before there's a change in the ejection fraction, you fix it before there's remodeling, you fix it before there's dilatation, you fix it before there's about a heart failure, you fix it if they're starting to have angina, got chest pain, and they need a bypass at the same time. You fix it at the right time, they're going to be fine. So people walk around with prosthetic valves. You might meet somebody in the elevators when you're working in the hospital and you hear somebody's going click, 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 click. Has anyone heard that? Yeah, that's their valve. You can hear it if they have a metal valve. They have a porcine valve or an equine valve. Do you think you're going to hear anything? Nope, doesn't make any sound at all if it's tissue. So if they have a tissue valve, do they need warfarin anticoagulation? Nope. If they have a mechanical valve, yes, they need it for life. That's one of the big disadvantages of using mechanical valve. If they have a homograph, they do not need anticoagulation for stroke. Do they need antibiotic prophylaxis if they have an artificial valve? Hopefully everybody said yes. I'm going to get poll everywhere put on these, so I'm going to start seeing how many of you say the right answer. The right answer is yes. Yes, they need SB prophylaxis. Doesn't matter if it's metal or plastic or pig or cow, they need antibiotic prophylaxis because it's not normal. It has a different shape and has crevices in places where it's going to collect antibiotics. Okay, aortic sclerosis, that's not a T. A lot of people get this, and this is just degenerative, and it makes a sound and sounds a lot like aortic stenosis. Same kind of murmur. What kind of murmur was that? Aortic stenosis. Systolic what? Crescendo, decrescendo, or ejection murmur. Systolic ejection murmur. So it might sound like that. What do you think would happen if you had aortic sclerosis and you start creeping up and listening in the neck? It won't transmit like aortic stenosis. So that's one way you can tell the difference. And the symptoms are different, and they don't have as bad as symptoms of it. It'll show up on the echo. But we see that. They'll have 3 leaflets. They won't have bileaflet. But it's not normal to get calcium and sclerosis in your valves. So it's a problem of our society and our diet and our aging that we get that problem. And inflammation is a big cause of that. It's a new thing. So those of you that are interested in inflammation, after you've watched The Widowmaker, the next thing you're going to watch is called Fed Up, another documentary all about sugar. Who's seen it? Isn't that a great program? It's about how sugar has crept into our diet. But sugar and white flour also causes heart disease because it causes inflammation of our blood vessels. So that's why we're getting sick, because we don't eat whole foods. And who knows what the rest of that stuff does, the preservatives and the colors and all that bad stuff. Okay. So now we're going to talk about the last thing really quickly, aortic insufficiency, which we'll practice listening to in the class. This one makes a diastolic murmur. So you're going to have to memorize what conditions make diastolic murmurs. That's mitral stenosis and aortic insufficiency. The rest make systolic murmurs. Aortic stenosis, mitral regurg, systolic murmurs. We're going to go over this and over this. This is not the last time. Okay, so this is just the beginning of the marination here. Okay? So we'll get it. Don't panic like, oh my gosh, how much, she said, all this stuff, I'm never going to remember any of this. You will. We're going to do it over and over again. Be okay. So aortic regurgitation sounds like this. It is falling back into the ventricle at what part of in the cycle? Diastole. So it's bump, 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 bump. Okay? It's after the second sound, it's a blowing, high-pitched blowing diastolic murmur. Which part of the stethoscope are you going to hear it best with? High-pitched blowing diastolic murmur. High-pitched, did I say low? High-pitched blowing diastolic murmur. Bump, bump, pow. Bump, bump, pow. Okay, so what do you hear high-pitched sounds best with? Oh, you're fishing. There's only 2 choices. It's a diaphragm. Okay, so you're going to listen to the diaphragm, and in the lab, I will show you the technique of how you listen to it. There's a really good way to hear it. And then one of the docs that I worked with, Irving Franco, he made the patient get on their hands and knees like a dog on the table and listen underneath them, get that heart way close to them. But we'll do a variation on that, so it won't be quite as nasty. So anyways, so the valve, the leaflets don't close completely, and some blood leaks back into the left ventricle. Tolerated very well, maybe never ever need valve replacement for that, because as long as the ventricle is strong and it's not doing what? Remodeling, dilating, enlarging, it'll be okay. And it usually doesn't get hypertrophied with aortic regurgitation, like because it's not straining and pushing hard against the stenotic valve and having to thicken to get it past that. So, but it can dilate over time if there's enough of that going on. If it's really severe aortic regurgitation. Okay. So if the aortic root dilates, you've all heard of an aortic aneurysm, right? So that's a commonplace, and usually caused by what disease do you think might make the aorta? A disease you all know about. Cause the aorta to widen at the top. The thing that you're going to be treating half your patients for. Actually, it's like 90%. Almost everybody has hypertension by the time they get to a certain age. So the hypertension will dilate the aorta and also stretch the annulus and cause aortic regurgitation. Marfans, we talked about, that can destroy the ring. Hypertension is the most common. Syphilis, can you get a vasculitis from that? It can destroy the ring. Aortic dissection. If you have an artificial valve in there, sometimes it rips away. You've got an infection around your valve and you've got an abscess there. It also you can have a perivalvular, or you can have dehiscence of the valve and you can get perivalvular leaks, different from in between the leaflets. We'll talk about this some more, but I guess I'll just show you we got like 2 minutes. Okay, come here, Bob. Sit right here. Okay, so of course you gotta you're gonna listen in the second space. Okay, and with which part of the stethoscope? Okay. Would you ever listen over their clothes? No. No. And so I hate that in OSCEs. When you start listening to people to their clothes, so I'm just pretending here. Okay. So you put first you put your stethoscope there, so you're in the right place. You don't bend him over. Let's say his gut stuck out of here, and I'm trying to have it. Then I'm having him bend over, and he's got this gut out to here. It's like, oh, how do I get that stethoscope past that gut? So you're gonna have a lot of overweight patients. So you put it there first in the second space, and then you're gonna support your patient. You put your hand on their back, and then you make sure that they're pushed back on the chair all the way to the back of their knees, so that they don't fall off the edge of the table. We don't have that here, but I would make sure he was sitting back as far as he could. And I'd say, Bob, I'm going to have you take a deep breath in, and I'm going to have you push all the air out. And when you've done that, then I want you to stop breathing. Don't take another breath in. Okay? And I do it with them so that I know how long they're holding their breath. So let's breathe in, breathe out, lean forward, more. And then I listen like that until I feel like they'll breathe when they have to anyways, if you don't tell them. They're not going to respect that. So that's how you do that. We've got to get them, and then you make sure that they don't do this. Let's say he put his hands like this, and he goes like that, and he's pushing like that. He's contracting his pectoral muscles, and I just hear a whole lot of noise from his pectoral muscles. So I say, no, Bob, just relax your arms. Just go with me here. Okay? And then I say, I couldn't hear good. So okay, let's do that again. Deep breath in. And out. Leaning forward. And I'm pushing him over. Okay, and then I listen. And then I close my eyes and I find diastole. And to find diastole, go ahead, get your shirt. Thank you. Thank you. Thank you. You gotta find diastole. Yeah, good job. Woo! So diastole comes after S2. So I can bump up. That flowing hyperstysolic murmur, it's really hard to hear. You got to have the room quiet. Okay? Pathognomonic, high-pitched flowing. And musical, sometimes it sounds like that. And often, this is pulse pressure. We don't have time today to go over pulse pressure, but I'm going to. Don't let this scare you. This is for fun. This is actually fun. Because you got all that blood in the ventricle, you got a low. Because you lost blood out of the aorta during diastole, you get a low diastolic blood pressure and a wide pulse pressure. And there's a little video on your own time. Look at this video of the pulse in that fingertip. It's on the sites on there. On the next slide, I think. But all these different ones, I've seen almost all of these different signs. But Quincke's pulse is where you can see a pulse in their finger from the increased pulse pressure. You'll get these like signs. I saw one called Shelley's sign. That's bobbing of the cervix. Someone had severe aortic insufficiency, a woman, and the cervix actually bobs. And most of them I've seen the head bob thing, like that with their pulse. Their head's moving, so you can see it in the finger. But at your leisure, watch that video of Quincke's sign, Quincke's pulse. So really cool signs of aortic insufficiency. Those are more cardiology board type questions. I don't know that they asked that one, but they would want you on the pans to know the pathognomonic high-pitched blowing diastolic murmur of aortic insufficiency. Okay? So talk about all the things that can cause a widened pulse pressure right there. Now, they do ask you, I don't know why, they ask you what an Austin Flint murmur is. And I think that's really advanced. But what happens is the regurgitant jet from the aortic insufficiency, the blood, remember, it doesn't go out the aorta, it comes down the left ventricle. So what's even on the left side too is the mitral valve, correct? Because after it goes to the mitral valve, it goes out the aortic valve. So they're really touching each other. So what happens is the regurgitant jet from the aortic valve pushes on the mitral valve, and it gives you a fake mitral stenosis. So you also get a diastolic rumble as if the patient had mitral stenosis. So you get both the high pitch and then murmur of AI, and then you got the low pitched diastolic rumble. A lot of times you only hear one of the murmur. It's too difficult, or you'll just hear the rumble. But they don't have mitral stenosis. They got aortic regurgitation, but it sounds just like mitral stenosis. So they ask you this question. I don't know. It's like coarctation and pheochromocytoma. They have an Austin Flint murmur. They got all their like favorite things they ask you that are not common, but they want you to know what an Austin Flint murmur is. So it sounds just like mitral stenosis, but it's not. So you can replace the valve. Here's some pictures of there's a mitral valve. That's a tilting disc, not used too often. Cosgrove at the ring I told you about. So I think that's an MRI picture, and you can see like each of the suture lines and stuff for that. Or this very common. This is Carpenter Edwards. The leaflets are made out of pericardial tissue from an animal. It's soaked and it's in it biologically inactive. You don't have to take immunosuppressants when you have that. And so that's the part where I cut the sutures. They sew that ring in there. I watched many heart surgeries, and it takes. And the Star Edwards is not used so much very often, but you're going to see these on people's chest X-rays, the ball and cage, because they have to anticoagulation, and they're getting more towards doing this TAVR procedure I told you about. So you'll see less and less of these, but some will come by. This is the one that you heard clicking in the elevator. And this one, a St. Jude mechanical valve, another tilting disc one. And there's a TAVR catheter that they put through the groin, and then they blow it up and push the old valve out of the way, and they have this artificial one. So since 2011, they've been doing these. There's a homograph out of a cadaver. They cut that out, and then they put that in the patient part of the valve. Another bioprosthetic, just a kind of a lower profile one. Another bioprosthetic. And Star Edwards again. So even though it was discontinued in 2007, they could have that thing for 20 years, so you're still going to see those in people that had it in 2007. And Cock brand and Medtronic, they all look pretty much the same. And that's it. Okay, thank you.
Thank you.